How many people either have or have access to CGMs, or continuous glucose monitors? 2 hands. All right. I think this is going to change over the next several years. And that's the purpose of why I wanted to do just an introductory component, especially to follow up on what Matt was saying about all of the injectable lectures. I don't envy him for having to go through all the pathophysiology of all the pills and shots and everything. So maybe this helps ram home a couple other ideas when it comes to complications in treating diabetics. So as our first patient, there's 4 patients, in case you're interested in following how long this is going to take. The first one, TK, 78-year-old, white female, diabetic for decades. Keep in mind that diabetics are now living longer since we have more options for care. Comes to me on 3 oral medications as well as Byetta. Still has an A1C of 8.9 despite full compliance, which I can confirm, with medications and decent diet. A C-peptide was found to be low, so I put her on 1,000 milligrams of metformin BID plus 40 units of Lantus. She was also given Humalog before meals. Due to the fact that she was new to that, I believe it was a set amount as opposed to a carb ratio, something like maybe 5 or 6 units before each meal. Now, to first start, before anyone panics and think this is like some sort of earthquake data or other issues, that CGMs are designed to be placed on your body. It's very similar to an insulin infusion set with a diabetic pump. And they record sugars, and you get roughly 260 sugars a day with those. And so the end result is you effectively get a continuous line showing what their sugars are doing. If you will, start with the area right down here where the green line starts in the bottom. That's when we first hook up the device. So it shoots way up here, zigzags around, maxes out on the device. Then you roll over to the left side. This is day 2, okay? So it just rolls along. Here's the pink line, wraps around, comes over here, and then you're over with the blue line or black line or whatever color that is, but somewhere over there. And so it's continuous. It's all one consecutive line, each color representing a different day. So the first grid looks like this, and sometimes it's a little hard to follow, but that's your overview page. You can kind of see what they did. I run them for about 5 days. You have to run them for 3 days for Medicare coverage, but either way, I run them for a little bit longer because I like to put them on Thursdays. Thursday and Friday are weekdays, Saturday, Sunday are weekends. You get a little bit different pattern, rolls over into Monday, okay? So that's just my rationale for doing it the way that I do. So now that we had a crash course in CGMs and how that operates, that you can then break the screens down into individual days. So this is one of the days right in the middle of it all. And then when you look at the data, first of all, these little blue stars that you see along the lines, these are when the patient checks their finger stick blood sugars, okay? They check it and record it, then we enter it in the computer. It's designed to confirm and make sure that it's corresponding with the data from the CGM device. And sure enough, these are pretty close to being on the line each one of those times. They usually are. It's a pretty accurate device. A CGM measures interstitial blood glucoses, meaning there's about a 15-minute lag between what an interstitial is and what a capillary blood sugar is. So there's usually a slight delay between those, but they're pretty close. Down here on the bottom, the little diamonds are when people eat. They keep a very detailed log on what they're eating, try to estimate the number of carbs, but more importantly, they just write down whether it's some chicken and rice or whatever they ate for that meal. And then we can go back and look at it if necessary to see if any one particular food is really driving people up on their sugars. These little teepee-looking things are whenever people inject insulin, okay? So logically, most of the time, the one way over on the right is usually Lantus. The rest of them tend to be meal times, and sure enough, they're paired with a meal. So we kind of got the general idea how these go. Okay. So in her case, what kind of things do you notice? That she starts off with a very high sugar, and we get an extreme drop after we eat. So what does that imply over what she's doing? Overdosing or short-acting insulin, basically. So she's completely cratering her sugars over here to the point where it goes below where the sensor can read, which is either 30 or 40. So that's not ideal. Of course, at least she does the appropriate intervention here, and you have an unopposed meal. She's eating something without giving insulin to try and bring her sugars back up here. So then it just sort of keeps working its way up all the way up into the end of the evening. The final one, I don't put a lot of emphasis on this page, and I know you can't read all the data, but basically it breaks it down into a number of hypoglycemic events and the percentage of time that you're in certain ranges. More graphically, you just look at the pie graphs. That this final column, each one of these is a different day. And so one day she never got in range. Not 1 minute was spent between 70 and 140 on her glucose. This is the average, the amalgam over those 5 days. So 3/4 of the time she is above 140. Clearly not controlled, but she has, a reasonable percentage, about 10% low, where she's below 70. And that's something you don't really want either. So she's very labile, bouncing around. What would you recommend for that kind of a treatment regimen, realizing that now she's on Lantus, metformin, and some short-acting insulin? Therein lies the complexity. There's kind of some mumbling like, maybe a little bit more Lantus. This lady I put on a pump. I put this lady, even though she's 78 years old and a type 2, I put her on a pump, her A1C is 7.2. That sometimes when you have very labile swings and you can control lockout mechanisms on what they're doing, and there's certain periods of the day that they're notoriously low, and you don't want in the night, you can control what she's getting overnight with the basal rates. She's actually done really well with that. We were a little worried with these big drops that she was overdosing herself, that might be a concern. But once we programmed kind of a more conservative carb ratio, more like a 1:20 or 1:25 initially, then she can count it. Even if she's off a little bit by entering the number of carbs, there's kind of a fudge factor introduced with that. So it's an option. There's not always a right answer, wrong answer, but I just want people thinking about different protocols and how they address these patients and the injectables. Patient 2, 61-year-old white female, type 2 diabetes for 7 years. Takes 30 units of Lantus, 500 metformin BID, can't take any more than that due to diarrhea. 5 milligrams of glyburide in the morning, and she's all ticked off that she just can't get her A1C below 8.2. She brings me Microsoft Excel files with her sugars and emails me them. So she's frustrated, says, hey, look, my fasting sugars are in the 120s, 130s. They're not all that bad. What's the problem? So we hook her up to a CGM. We see this. Now, first of all, when we first hook them on, sometimes you get this weird zigzag pattern. That's more of an artifact. So don't use that, okay? It just shows a general pattern. The rest of this is pretty accurate. The skip happens sometimes when you leave the device on too long. So if you try leaving it on for a week, you get more and more of those. So that's also an artifact. But in general, you do see a pattern here, correct? We pick one day, sure enough, we got good entries. She's checking her finger sticks several times a day. And we have our Lantus infusion here. These various other things are various medications and meals. These little stars are the medications with the metformin. These are other activities that normally people don't even record those. In her case, at least one of these was actually intercourse, which is interesting. So that didn't really affect her sugar. And here she's eating. So what are you seeing here? You're seeing associated with the meals, pretty big spikes postprandially, right? So obviously there's more of an emphasis on trying to get her postprandial sugars down. Now, ordinarily you would go to your short-acting insulins, regular, Apidra, any of those options. She also elected to go for a pump by her decision. I would have normally done more of your classic MDI approaches with the multiple daily injections, but she actually preferred to go to pump, and she's doing well as well. So you just have to be on the lookout for where the postprandial element is, and don't just ramp up people's Lantus if they're a type 2, okay? That she had an A1C that was high, Lantus was about 40, says her morning sugars are okay, and sure enough, they were. So if you just keep ratcheting up the Lantus, that's not always the solution, okay? Because sometimes there's a tendency, until their A1C is at goal, people just keep ratcheting up the Lantus. And that can be a mistake. You can start getting the low blood sugars at that point.